Thank you, Mauro, and to the organizing committee for inviting me here. It's a real pleasure to be here in Brazil, and I'll show you why. Because this is what I come from in Boston, where we have lots of snow and very cold weather in the winter. So it's a real thrill to be here in this beautiful country with many friendly and beautiful people. However, Boston is fairly nice in the summertime, and this is my hospital, Massachusetts General Hospital, which we are on the Charles River, and we have the Esplanade, and this is, I have beautiful views out my office window of the Esplanade and sailing, and I hope you all will get a chance to visit Boston sometime in the summer. And if you are thinking about coming to Boston, you might consider a course that we have, which is in 2019, so not this June, but the next June, 2019. It's a 4-day, very comprehensive course on all aspects of head and neck and endocrine pathology, soft tissue, skin, squamous cells. It's everything you can imagine. And Justin Bishop from Hopkins is going to be one of our guest speakers. Okay, so with that as a little bit of intro, let me now go into salivary gland cytopathology, and this is an area that I'm very enthusiastic about. As you know, we've seen, cytology has seen a movement towards the development of many different defined reporting systems, from the Bethesda system for cervical cytology to thyroid Bethesda system, which is now in its 2nd edition, and the urine, the Paris system. And so now we have to ask, is there a role for a salivary gland FNA reporting system, and can it be effective? And I hope that by the time I end this talk that you will shake your head and say, yes, I think that would be appropriate. Okay, so this is the reason on both surgical pathology as well as cytopathology that salivary gland is so difficult. And that's because salivary gland tumors are one of the most heterogeneous groups of neoplasms for an anatomic site in the body. And here in the background, these are just some of the different FNAs of different tumors that could be encountered. So it's really one of the more difficult areas. So you would ask yourself, what role is there for salivary gland FNA? Before we get into the details of salivary gland fine needle aspiration, I just want to give you a little bit of background that's important to salivary gland tumors. As we know, in general, salivary gland tumors are fairly uncommon, although at my institution, I'm also at the Mass Eye and Ear Infirmary, and we see lots of head and neck tumors, including lots of salivary gland tumors. They are more common in older adults, in women, and especially the parotid gland, which is here anatomically. Over 75% in general of salivary gland tumors are benign, but that's because a majority of the tumors do occur here in the parotid gland, where many of them are pleomorphic adenomas. And that's very good news for us who are cytopathologists, because we do an excellent job of diagnosing pleomorphic adenoma by FNA. And you might think that's trivial, but it's not, because that has very important implications for the management of the patient. We will often see these tumors in the parotid gland here in the periauricular or preauricular area. You may see them down here at the angle of the jaw, and the clinician will send you a patient. They think it's a neck lymph node, and you do the FNA, and you find out that it's a parotid gland tumor because it's here at the angle of the jaw. Sometimes you'll see a patient with a mass in the cheek, and oftentimes that's accessory parotid gland tissue that occurs along Stenson's duct that goes over the masseter muscle. And so if you do an FNA of a cheek mass and you see a salivary gland tumor like a pleomorphic adenoma or an adenoid cystic carcinoma, it's probably coming from accessory parotid gland tissue. Now, it's extremely important for all of us in this room as cytopathologists, as well as for our clinicians, to understand something about the risk of malignancy in salivary glands. The risk of malignancy in general is inversely proportional to the size of the gland. So if you have a mass in the parotid gland, there's about an 80% chance that it's going to be benign, and many of those are going to be pleomorphic adenomas. The problem starts arising when you move down to the submandibular gland, which we have right there, where the risk of malignancy is about 50%. 50% benign, 50% malignant. And then if the patient presents with an intraoral mass, such as a palate mass, possibly from a minor salivary gland, the risk of malignancy goes up closer to 90%. So again, the risk of malignancy is inversely proportional to the size of the gland. So how effective is salivary gland FNA? The effectiveness overall is pretty good, especially for sensitivity in the 86 to 100% range. The overall specificity, however, has more of a spectrum, and that's because of the heterogeneous nature of the salivary gland tumors. The accuracy of salivary gland FNA varies. It's pretty good for distinguishing low-grade and benign tumors versus high-grade malignancies, but less good for a specific diagnosis. Now, how many of you on surgical pathology use frozen section for your salivary gland tumors? Not many people use frozen section. Well, I would recommend that you suggest to your head and neck surgeons that frozen section can be very valuable. And in fact, the combination of FNA plus frozen section has an even greater accuracy than either of these alone. So at our institution, we always do FNAs on our parotid and salivary gland tumors. We don't always get an exact diagnosis. And then the clinician, when they're taking out that gland, will send the material for frozen section. And in the frozen section, knowing the FNA diagnosis, we can kind of corroborate those and get even greater accuracy. So before I start talking about the Milan system, I just want to quickly go over 4 myths. And I think everybody in the room knows the answer to these 4 questions. However, it's our job to educate our surgical pathologists and our clinicians about these. So FNA causes seeding of the needle tract. Whoops. That is false, as we know. Seeding of the needle tract generally is associated with large core needle biopsies, and that's one of the reasons that we have to educate our clinicians that fine needle aspiration is the way to go, because if you are dealing with a malignant tumor, you're not going to get seeding of the needle tract, and they're not going to have to worry about excising that area where the biopsy was done. FNA causes pleomorphic adenomas to rupture. I mean, a lot of clinicians and famous pathologists have said this for a long time in the past, but we know that that's not true. In general, if pleomorphic adenomas are left behind in the patient and spread, it's generally because of bad surgical technique or for some other reason, but not because the FNA caused that problem. What about nerve damage? I know lots of patients come into my FNA clinic and I do the FNA on them and they're like, oh, are you going to damage a nerve, or I'm worried. Generally, FNA, you may tweak a nerve, they may feel a little bit of pain, but FNA in general is not going to cause significant nerve damage. Again, that's something that you can encounter with large core biopsies, and that's also one of the reasons that we leave those to our interventional radiologists, because there is a risk of doing a large core biopsy in the parotid region and actually taking a sample of the facial nerve and causing significant damage. The last one is FNA causes salivary gland tumors to infarct. And this is one where the answer is partially true in rare cases. especially things like Warthin tumors. The oncocytic tumors tend to be more inclined to infarct for some reason. However, in my experience, I'm also a surgical pathologist in head and neck, and in my experience, I've never had a case where the FNA caused a tumor to infarct and it was a malignancy that I was not able to diagnose. I've never had that happen. In most cases, it was a Warthin's tumor, and we were able to recognize that even on the surgical resection. All right, let's start talking now about this Milan system. So why do we need a reporting system for salivary gland cytopathology? Well, first of all, when we're thinking of diagnosing a salivary gland tumor by fine needle aspiration, there's diagnosis, there's reporting, and then there's management. So we start off with our salivary gland FNA, as you see there, and the next step is we are going to look microscopically at the sample that we got. We're going to make a diagnosis based on cytomorphologic features, and hopefully you will have enough material, maybe in a cell block, to do some ancillary studies, and in that way maybe to make a more effective definitive diagnosis. So the next question is, once you've formulated the diagnosis in your mind based on the cytomorphology, how are you going to report it? How are you going to transmit that information to your clinician so that they understand what the implications are in terms of the management? And that is where reporting systems come in. So the Milan system that I'm going to tell you about, we do discuss in our atlas aspects of diagnosing the tumors, but really the important aspect of all of these reporting systems is not as much in the diagnosis as in how we transmit that information to the clinician, how we report it. And it's very important that we have some kind of uniform reporting system, I think, throughout the world. Otherwise, we're doing the patient a disservice. And so how we report the fine needle aspiration, whether it be the Milan system or the Bethesda thyroid or anything else, is going to impact the clinical management. So let me just give you an example of why this is important for salivary gland. So if you saw these three images of a parotid gland FNA, and you see that we're dealing with a very basaloid tumor. Here's an alcohol-fixed smear, here's an air-dried smear, and here's a liquid-based thin prep that we have of the sample. So it's one of these basaloid neoplasms. This is probably one of the most difficult areas of salivary gland cytopathology. How are you going to report it? So here's our surgeon over here, and he's going to read this report. This is a low-grade matrix-producing neoplasm with basaloid features, blah, 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 blah. They don't know what the hell we're talking about. So we need some, and there's no implications for risk of malignancy or anything associated with that. What if we just call it basaloid neoplasm with matrix, suggestive of basal cell adenoma? Or we call it atypical, basaloid cells with mild atypia, and give a long note, a lot of verbiage that they're not even going to read? Or maybe you're convinced it's a basal cell adenoma and you call it negative for malignancy. In fact, it was actually a basal cell adenocarcinoma. So this is the problem that we're dealing with, and the surgeon needs to understand what it is we're talking about. He needs to understand what the risk of malignancy is for this lesion so he can have a discussion with the patient and decide upon the best management. And I'll come back to some of these management issues in a few minutes. So just to summarize, the current reporting confusion for salivary gland is due to a diversity of diagnostic categories out there. Which one do we use? Many people are just using these descriptive reports, which are long and verbose, and nobody can understand them. Some people are just using surgical pathology terminology, which doesn't always fit with cytopathology. And of course, no correlation with risk of malignancy or with the clinical management. So in order to formulate the Milan system, some of you may have participated in this. We actually had 2 online surveys, and we solicited folks, cytopathologists and others, to go online and to answer a series of questions. And from that online survey, we found that there was a general agreement that there was a need for a uniform reporting system for salivary gland cytopathology. And this will lead to clarity of communication with an implicit cancer risk, and also better exchange of information, of data across institutions and between different countries. And this is also going to be good for research. And overall, the goal of this is better patient care. And I think that's what this is leading towards. So this is what spawned the Milan system for reporting salivary gland cytopathology. This is a subset of the co-authors, the group, the very important group that worked on this Milan system and came up with the final reporting system. This was taken at one of the recent USCAP meetings. And I would emphasize here that this was a tremendous group effort. Folks from all over the world contributing to this. And for those of you who have seen it, this is the Milan System Atlas. It was published in 2018, and myself and Dr. Diana Rossi from Rome, Italy, helped to lead this effort. And we also had a number of folks who were core editors. And then in addition, we had over 40 co-authors from 15 different countries contributing to this. And the reason we wanted this to be international from the very beginning, so that it would be more accepted throughout the world. And we've been very impressed by its acceptance in many different countries. We also included among these 40 co-authors input from surgeons, as well as head and neck surgical pathologists in this effort. And again, the goal is to produce a practical classification system that's user-friendly and, again, internationally accepted. It is evidence-based. We definitely need more research published out there in the literature. Any of you who are interested in doing research, please contact me or reach out to others who are co-authors on this, and feel free to collaborate, because there's a lot of research going on right now to improve the literature out there on salivary gland cytology. So this Milan system correlates with a management algorithm. Again, I mentioned the print atlas, and there's also a web-based atlas that is in preparation that will have just thousands of images available correlating with the reporting categories and available through the American Society of Cytopathology. So I mentioned that we did these online surveys before the Milan system was formulated in order to find out what cytopathologists around the world were thinking of. We had in this survey over 515 international participants, and we got a lot of data, but I just want to mention 4 points from the data that we got. Again, the majority of individuals supported development of this reporting system. It was interesting to find that 81% of participants used radiologic guidance for their fine needle aspiration. Some of these nodules can be small in the parotid gland. Some of them may be small lymph nodes, and in those cases, ultrasound guidance can be very helpful. I also find that in the submandibular gland, the rate of non-diagnostic samples goes way up if you don't use radiologic guidance to do your FNA of the submandibular gland nodules. And that's also true for minor gland sites. 70% of participants use both air-dried and alcohol-fixed preparations. I will say that for salivary gland cytology, for us to do the best job that we can, It's probably also best to have both alcohol fixed and air dried preparations. If you only have liquid-based preparations, I think your diagnostic abilities will be somewhat limited, although it can be done. But in my opinion, it's best to have both alcohol fixed, air dried preparations, and even a cell block for cases where you may need to do ancillary studies. And with regard to ancillary studies, it was very disappointing. 62% of respondents do not use ancillary studies for salivary gland FNA. You know, that's fine. The Milan system is set up so that you do not need to make a specific diagnosis. However, if you want to go as far as you can and try to make a specific diagnosis, in many cases you probably will need to try to use ancillary studies. And we'll come back to that in a few minutes. So what are the diagnostic categories, the reporting categories in the Milan system? So they include non-diagnostic, non-neoplastic, AUS. I think you're all familiar with AUS from the thyroid Bethesda system. It basically means atypia. And then we have two neoplasm categories, benign neoplasm, and this one that has the acronym SUMP, which just means it's a neoplasm of uncertain malignant potential. Okay, I'll explain it more in just a moment. The next one is very familiar to all of us in the room, suspicious for malignancy, and then malignant. So actually, many of these categories, they're very similar to standard reporting categories that we've used for decades in cytopathology. And we did very closely try to mimic the thyroid Bethesda system in some of these categories. This is actually from the Atlas, and this chart is based upon a thorough review and analysis of the literature on salivary gland cytology. And so you can see that each of these diagnostic categories in the Milan system is linked with a risk of malignancy. I will say, and this is also true in the thyroid Bethesda, that the non-diagnostic category does have a little bit of an elevated risk of malignancy, and that's because, especially if you're not using ultrasound guidance, you may actually miss the salivary gland lesion. But what I'd like to point out as well is that as we go from the atypical category of about 20% risk of malignancy up to the uncertain malignant potential category of 35%, and then further up we go to 60%, and then closer to 90% as we move through the suspicious and malignant categories. Now, which are the reporting categories in this Milan system that are probably going to be the most popular ones that are used? Neoplasm benign, not surprisingly, is going to be one of the most common categories, and that's very good. It's associated with a risk of malignancy that's 5% or less. And the reason for this is that many of these salivary gland FNAs are from the parotid gland, and many of them are pleomorphic adenomas and Warthin's tumors, and we can easily call them benign, and that can be very helpful for clinical management. Non-neoplastic, that's also a very common category for salivary gland, and that's because it includes all of those inflammatory conditions that you can encounter in both the parotid as well as in the submandibular gland. The neoplasm SUMP category would be next in line, and then the least common tend to be the malignancies. Remember I said salivary gland cancers are fairly uncommon. The non-diagnostic category, it really depends on the institution and the site. So if you have a larger nodule and it's in the parotid gland, the non-diagnostic category is probably not going to be used much. But if you're dealing with a smaller nodule, such as in the submandibular gland, and you're not using radiologic guidance, then you may have a much higher non-diagnostic rate. Suspicious for malignancy and AUS tend to be less frequently used. Now, I just wanted to mention these are just four examples of articles that have come out already and been published on the Milan system, and actually there are about 12 to 15 articles now that have either been accepted or published dealing with the Milan system, and there's a lot of research going on in this area. And for those of you who are interested in research, I invite you to try to collaborate with people who are doing some of this salivary gland research, because again, we want this to be an international effort. Before I go through each of the diagnostic categories and tell you a little bit of detail about them, I just want to say a few more words about the clinical management considerations for salivary gland cytology and the role of the Milan system. So in terms of salivary gland FNA, how does it impact clinical management? So this is how it really happens. If we can call a salivary gland FNA non-neoplastic, some kind of inflammatory condition, then that patient is probably going to just get good radiologic imaging and clinical follow-up. They can possibly avoid surgery. If I can call the lesion a benign tumor, or it's in this SUMP category, it could be a low-grade carcinoma, I'm not sure, the patient will most likely go on and get some kind of limited resection of their tumor, but they're probably not going to get a neck dissection, and the clinician's going to avoid any kind of nerve sacrifice. There are many lymph nodes associated both around the parotid gland and within the parotid gland that are subject to metastatic disease. And we often do FNA for metastatic tumors to intra and periparotid lymph nodes. So if we can make the diagnosis of metastatic, often skin cancer, to one of these parotid lymph nodes, then that patient is probably just going to have a limited lymph node dissection in the parotid region. And then also along the lines of lymph nodes, if we can say that the lymph node is just reactive, benign, and we do flow cytometry and it's negative, the patient will just get follow-up. But if we use flow cytometry and we can say this is lymphoma, then the patient will probably get a hematology oncology consult, and they'll have that one lymph node excised to specifically classify the lymphoma. In contrast to these, if we make a diagnosis on salivary gland FNA of high-grade primary carcinoma of the salivary gland, and you don't even need to subclassify it specifically. Is it high-grade mucoep? Is it salivary duct carcinoma, or one of the other carcinoma XPA? It doesn't matter. If it's high-grade primary carcinoma of the salivary gland, that's going to guide the clinical management. And oftentimes it's going to lead to some kind of radical resection. Often the patient will have a neck dissection, and if the cancer is anywhere around one of the major nerves, especially in the parotid, it's going to be the facial nerve, there may be sacrifice of one of the branches or even of a major portion of the facial nerve. So this is how the FNA diagnosis is going to impact clinical management. So the next couple slides I want to show you are from the head and neck surgeon's perspective. So this is input from one of our surgeons at the Mass General Hospital. He wants to know, so what are the surgeon's priorities? What does he want to know? He wants to know, do I need to perform an operation on this patient that you did the FNA on? If an operation is needed, what type of salivary gland resection needs to be done? Are we going to do an extracapsular dissection? And that's often done these days. It used to not be done, but it's often done these days on some of these pleomorphic adenomas. Is it going to be a superficial parotidectomy, for example, a subtotal parotidectomy, for example, or some kind of total salivary gland resection, a more radical surgery? Is a neck dissection going to be necessary? And you know, some of these tumors are occurring in kids. We have to be very accurate with our cytology because we don't want this kid to get an unnecessary neck dissection. And what is the likelihood? The clinician wants to know, what's the likelihood that I'm going to have to sacrifice the facial nerve? This is not a trivial thing. Patients We do not want to cause harm. We do not want to sacrifice the facial nerve unless we absolutely have to. And the surgeon will do everything they can to avoid a facial nerve sacrifice. So what does the surgeon want to know from us? He wants us to be as specific as possible. Now, I realize, again, the Milan system is established because we know that on cytology, we can't always get to a specific diagnosis. But the beauty of it is that even if we can't get to a specific diagnosis, we can tell him or her, what the risk of malignancy is for that nodule. So salivary gland FNA, it can be used as a screening test, but I think we can do even better, especially when we can get material for ancillary studies. So the clinician would love to know a specific diagnosis, but he would also be happy if we can just differentiate into benign versus malignant, and then either low grade versus high grade, because these are divisions that really will impact his decision making for the clinical management of this patient. And then the other thing that I would encourage all of you is that for cytology to remain relevant, we have to be ambassadors for cytology as well as ambassadors for the patient to help the patient. And we need to be at the table at these head and neck tumor boards where they're discussing patient care, because we are part of the care team. So I encourage all of you, if you're not already doing it, please try to get involved with your clinicians and go to the tumor boards and have input there. And also, I would say that's important for your surgical pathologist to do as well. Okay, so what I want to do now is very quickly just give you an overview, that the key salient points for each of these categories in the Milan system. The first one is non-diagnostic. It's pretty obvious. Not enough material in order to make a diagnosis. Generally, the maximum rate would be around 10%, and we would estimate, we don't really have a number for the number of cells that you would need. There's nothing in the literature, but based on the Bethesda thyroid system, we would say generally you'd want to have around 60 cells or so. It's just kind of a ballpark number. And this is going to lead to repeat sampling using ultrasound or CT guidance. Many of these non-diagnostic samples are FNAs where you only get benign salivary gland, non-neoplastic salivary gland tissue in the presence of some kind of mass lesion. And so the presence of only benign non-neoplastic salivary gland tissue does not explain the mass lesion, and we would classify those as non-diagnostic. On the other hand, if the patient comes in with just sort of bilateral diffuse enlargement without a defined mass, and you get benign tissue, you may decide to put that into the non-neoplastic category, but with a caveat, a note, telling the clinician that they need to correlate and follow up, because it's possible this may not be representative. Also, many of these non-diagnostic samples are going to be non-mucinous cyst contents. There are 3 exceptions to the non-diagnostic category. If you have any kind of atypia, we would recommend placing that diagnosis into the atypical category rather than non-diagnostic, because in terms of clinical management, the atypical category is more often going to go to surgery, whereas the non-diagnostic is going to get some kind of often non-surgical follow-up. Also, if you do an aspirate and you only get matrix material without sufficient numbers of cells, we would not call this non-diagnostic. We would put it into the neoplasm category, because this probably represents a pleomorphic adenoma. And then the third exception is if you get cyst contents that is mucinous, that should be in the atypical category, because we cannot exclude a mucoepidermoid carcinoma. Now, the non-neoplastic category, these are mostly inflammatory conditions, so acute, chronic, and granulomatous sialadenitis. It also includes reactive lymph nodes. So if you get an FNA of one of these periparotid or intraparotid lymph nodes and you have negative flow cytometry, you can call it reactive, and it would be in this non-neoplastic category. This is chronic sialadenitis, hypocellular with these basaloid groups, and some background chronic inflammation. Here's granulomas. I think this patient actually had sarcoidosis. And this aspirate over here shows inflammation and fragments of stones. So it's chronic silodinitis with silolithiasis. Okay, the atypical category. We felt that we needed an atypical category. We're using the same term that was used in the thyroid Bethesda system. So this is for those samples, and this should be used rarely. It's for those samples where you may have just a little bit of atypia present. You're not sure if it's even a neoplasm, but there's enough atypia or enough atypical features that you don't want to call it non-neoplastic. I mentioned already that the mucinous cyst should be in this atypical category, and that's because any salivary gland FNA with a lot of background mucin, you need to be very careful because the mucoepidermoid carcinoma, low grade, can be very tricky. It's not our friend. And you can get just a lot of mucin and not many cells, so you need to be careful about that. And then if your aspirate has little bits of atypia, but you're just not sure, is it a neoplasm or not, put it into the atypical category where the risk of malignancy is about 20%. And many of these cases will go on to require tissue biopsy or maybe even resection. Okay, there are two neoplastic categories, benign and uncertain malignant potential. We separate these out because the benign category, we want this to have a very low risk of malignancy, less than 5%, and that means that for some patients who may not want to risk the complications from salivary gland surgery, or for patients who are not surgical candidates, the clinician will feel comfortable following these patients, okay? A majority of these tumors in this category are going to be classic examples of pleomorphic adenoma like we have here in this alcohol fixed and the air dried preparation. And again, I hope everybody in this room, we're very accurate at diagnosing most pleomorphic adenomas. I'd say about 90% of them on FNA. Another common tumor in this benign category is going to be Warthin's tumor. Again, we do a great job with that. But other things that would be in this category include lipomas, schwannomas, and certain other tumors. Now, the neoplasm uncertain malignant potential category, I would say think of it as a category it's a neoplasm, but I can't entirely exclude carcinoma. So most of these are going to be low-grade cancers. The risk of malignancy is going to be about 35%. Those basaloid tumors, like I showed you that example of, is going to be in this category. And the clinician will know, okay, there's about a third chance that this is going to be malignant. Some of the pleomorphic adenomas in that 10% range that have unusual metaplastic changes, mucinous or squamous metaplasia, that will be in this uncertain malignant category, as well as other tumors like myoepitheliomas. And you know, we can evaluate for invasion, so I can't exclude malignancy, and I put it into this category. I don't really want to go into a lot of detail on this, but I will mention that in the atlas, we do subdivide this neoplasm category into basaloid neoplasms, oncocytic, and those with clear cells. It's not essential that you use that. We only put it in there as a guide for you to think about the differential diagnosis. And we even subcategorize these groups even further. But again, that's not important for the reporting. It's just for you to help you out in terms of formulating your differential diagnosis depending upon the features that are present. Suspicious for malignancy, again, we all know this category very well. It's a standard cytology category. It's for those aspirates of a salivary gland tumor that are highly suggestive of malignancy. I'm pretty sure that that is adenoid cystic carcinoma, but maybe I have a limited sample, I don't have any clinical information, and if I call it adenoid cystic, the patient's going to get a radical surgery. So maybe I'll put it into suspicious for malignancy, suspicious for adenoid cystic, and then our clinicians will do a frozen section and confirm that diagnosis. This also kind of looks like mucoep. It kind of has a mucoid background, and there's some maybe mucin-containing cells. Maybe I don't have any material for ancillary studies, I'm not quite sure, and so I'll put it into suspicious for malignancy. And many of the high-grade cancers that you do not have a good sample of may also fall into the suspicious for malignancy category. In the malignant category, it's for those aspirates where you look at it and either it has classic features of one of the standard cancers in the salivary gland, or it just has overt malignant features. You may not know which cancer it is, but you can say this is high-grade cancer, or this is lymphoma, and you can place it into the malignant category. Very importantly, once you reach the diagnosis of a malignant neoplasm on salivary gland FNA, it is important, if you can, to try to make a specific diagnosis. Even if you can't do that, it's important, if you can, try to grade it into low grade or high grade. We can't always do that, but if you're pretty sure based on the atypia that it's high grade, then I would indicate that in your report, because that will help to guide the clinical management. Other malignancies such as lymphomas, sarcomas, and metastases are also included in this malignant category. So here's an example of an overtly malignant FNA. If you have ancillary material, you can do the androgen receptor and show that this is salivary duct carcinoma. This is a classic example of adenoid cystic carcinoma. Maybe the clinician tells you, or you did the FNA, you know the patient has nerve symptoms already. Any nerve symptoms, it's carcinoma until proven otherwise. Here's low-grade mucoep. I do not need ancillary studies to make that diagnosis. This is this weird mixture of mucinous cells and epidermoid cells. That is mucoepidermoid carcinoma all day. And this is an example where we would have positive flow cytometry, and this is diffuse large B-cell lymphoma. So this chart, hopefully this PowerPoint will be available to you, but this chart is just something that I put together. When I get a salivary gland FNA, I kind of look at it, and right from the get-go, I kind of know that there's certain tumors I can usually make a specific diagnosis, like pleomorphic adenoma and Werthin tumor. Others where it depends on the nature of the tumor as to how far I can go. So adenoid cystic and mucoep depends on the nature of the specimen, and ancillary studies if I'm going to be able to make a specific diagnosis or not. And then some tumors like the basaloid tumors, almost all the time from the get-go, I know I'm just going to put it into that uncertain malignant potential category. So let me just finish up by saying one word about ancillary studies. I'm going to talk a lot more about this in detail on Friday morning, but there have been a lot of improvements in terms of immunochemistry and molecular testing for salivary gland. It's very, very rich now. We've got a lot of tools at our disposal that we can use, and this is great. So it's very important when you're doing the FNA, if you can, try to get some extra material to make a cell block so that you can do some of these ancillary studies. And we prefer cell blocks to address this. And I think this is very important. Our careers in some ways are at stake. If we do not make the effort to obtain material for ancillary studies, FNA will become less relevant. They're going to start doing core biopsies or other things besides FNA. So we need to make the effort to get the material, make cell blocks, and do ancillary studies and show that we can actually do this and we don't lose cytology over to the surgical pathologists. And there are many ways that we can apply ancillary studies. We'll talk more about that on Friday. This is just to show you some of the immunochemical stains, for example, for pleomorphic adenoma, PLAG1, mammoglobin for secretory carcinoma, DOG1 and SOX10 for acinic cell, CD117 and MIB for adenoid cystic carcinoma. Again, we'll be hearing more about that. And these are some of the known molecular changes associated with many of the more common salivary gland tumors. So if you actually do molecular studies and you have material, you can actually make a specific diagnosis, so going further than you could just on cytomorphology. And these are actually 3 examples of FISH analysis for adenoid cystic carcinoma, mucoep, and secretory carcinoma. So going forward for salivary gland in the future, we look forward to the implementation of the Milan system. We hope that this will become universal, because I hope I've convinced you we really need at least to have a uniform reporting system, right? We're currently doing a reproducibility study, which you'll see the results of published within the next year. We need more research. We're going to improve our grading of malignant tumors. We're going to refine the risk of malignancy, and we're going to improve correlation. And then I would just like to mention to you that if you guys are involved in social media, I encourage you to follow us on Twitter. Also, I'm on Twitter. And if you have questions, feel free to email me at that email address. And with that, I very much thank you for your attention. I look forward to the implementation of the Milan system, and I hope you enjoy using it. Thank you.